Welcome to The Explainer, everyone. Today we're tackling a clinical challenge that every single trainee needs to get right, diagnosing heparin-induced thrombocytopenia, or HIT. Think of yourself as a detective, because that's what this takes, and we're about to walk you through the case file.
So here's the big paradox, right? We give patients heparin all the time to prevent blood clots. So how on earth does it sometimes do the exact opposite, triggering massive, life-threatening clotting? Getting to the bottom of this is the key to the entire mystery.
And let me tell you, the stakes are incredibly high. 20%, that's the potential mortality rate if HIT goes untreated. It's a sobering number that reminds us why spotting these clues early and acting fast isn't just good medicine, it's absolutely critical.
So here's our game plan for cracking this case. First, we're going to understand the crime scene, what HIT actually is. Then we'll learn to spot the clues at the bedside. After that, we'll pull out a special tool to quantify our suspicion, send our evidence to the lab for forensics, and finally, we'll put all the pieces together to solve it.
All right, first things first. Every good investigation begins with understanding the nature of the crime. Before we can identify our culprit, we need to know exactly what we're looking for, and just as importantly, what we can ignore.
So, the first thing you absolutely have to get is that HIT isn't your typical drug side effect. No, this is a full-blown rogue immune response. What happens is heparin links up with the protein on our platelets, and this new complex looks foreign to our immune system. The body then freaks out and creates these autoantibodies that don't just attack the complex, they go on to activate all the platelets, turning on a massive system-wide clotting cascade.
Okay, and this is super important. You've got to know about the two main suspects on the scene. Think of HIT type I as the harmless imposter. It causes a small dip in platelets right after you start heparin, but it's not immune-related and it goes away on its own. HIT type 2, well, that's our real culprit. That's the dangerous antibody-driven reaction we've been talking about, the one that leads to devastating clots. From here on out, when we say HIT, we mean this dangerous type 2.
So we know what we're looking for, but how do you actually spot it when you're on the wards in a real patient? What are those telltale signs, the little clues that should make you sit up and pay attention?
These are the red flags, the alarm bells that should be going off in your head. A dropping platelet count is the classic sign, but you have to remember the 50% rule. A drop from 400,000 to 200,000 is just as worrying as a drop from 100,000 to 50,000. It's the relative drop that matters. And here's the key. Never, ever wait for a clot to form. The falling platelets are your warning shot. They're telling you that a thrombotic storm might be just around the corner.
You know, timing is probably one of the most powerful clues you have. It's like a criminal's MO. The immune system needs time to mount that attack, to build those antibodies. That's why that 5 to 10-day window after starting heparin is just so classic. Now, what's the exception? The patient who's seen heparin recently. They might already have those antibodies locked and loaded, ready to go. For them, HIT can strike, and strike fast, sometimes within hours.
All right, so you've got a hunch, right? The clinical picture looks suspicious. But how suspicious are we talking? Is this a vague lead, or do you have probable cause? To figure that out, we need to move from just a feeling to an objective score. And for that, we have an essential tool, the 4T score. And I really can't stress this enough. Before you even think about ordering a fancy lab test, you have to calculate the 4T score. This isn't just a checklist, it's a validated system that helps you figure out the odds. It keeps you from over-testing low-risk patients, and more importantly, it tells you when you need to act immediately on a high-risk patient.
And this is how it works. It basically takes everything we've just talked about and turns it into a number. You've got your 4 T's. First, thrombocytopenia. How big was the platelet drop? Second, timing. Did it happen in that classic window? Third, thrombosis. Is there a new clot? And finally, and this is key, are there other obvious causes for the platelets to be low? You give points for each and you add them up. And this is where the rubber meets the road. If you get a low score, 0 to 3, you're pretty much in the clear. The risk is less than 1%. You can stand down. But if you hit that intermediate or high score range, everything changes. The probability shoots way up, and your marching orders are crystal clear. You have to presume the patient has HIT. That means you stop all heparin products right away, and you start a different anticoagulant, all while you wait for the lab to catch up. You act first.
Okay, so we have a high pretest probability, we've got our suspect, now it's time to send the evidence to the lab for some forensic confirmation. This is how we prove our case beyond a reasonable doubt.
Now, you've got to know the difference between your two main lab tools here.
First up is the immunoassay, the ELISA. Think of this as casting a wide net. It's super sensitive, so a negative result is fantastic. It pretty much rules HIT out, but it can sometimes pick up innocent bystander antibodies. The second test, the functional assay, like an SRA, is like getting a DNA match. It doesn't just see the antibodies, it proves that they're the kind that actually activate platelets. It's the gold standard for ruling HIT in.
Now listen up, because this is a pro tip. When you get that ELISA test back, do not just look at whether it says positive or negative. The real story is in the number, the optical density, or OD value. A weakly positive result might not mean much, but a strongly positive result, that is a huge piece of evidence.
And this chart shows you exactly why that number is so powerful. Just look at this. If the OD value is low, the chance that your gold standard test will be positive is tiny. But once that OD value climbs up over 2.0, boom! The probability of having true, functionally active HIT antibodies is over 90%. In a patient with a high 4T score, a result like that pretty much solves the case.
All right, let's put all the pieces of the puzzle together. We've followed the clues, we've scored our suspicion, we've looked at the forensics from the lab. It's time to close the case file and make the final diagnosis.
So here it is, the whole playbook from start to finish. You suspect it based on the clinical signs. You score it with the 4 T's to see how likely it is. You act immediately if that score is intermediate or high. Then, and only then, you test. Finally, you interpret those lab results in the context of everything else you know to make the final call. And look, like any good detective, you can't get tunnel vision. Low platelets are incredibly common in hospitalized patients, so you always have to check your assumptions. Could this be sepsis? Could it be DIC? Could another medication be the real culprit? Ruling out these other common suspects is what makes your diagnosis of HIT truly rock solid.
So let's end with this scenario, a situation you are absolutely going to face. The answer, of course, is that you act right now. When your clinical suspicion is high, you cannot afford to wait for the lab to confirm what your detective work is already screaming at you. You stop the heparin, you start the alternative treatment, because in the case of HIT, waiting for forensics can be a disaster.